Thank you very much. That was such a moving session right before ours, and it really puts into context for me why we're here and why we do the work that we do. So I've got NIH grant funding from the United States, but otherwise no industry-related conflicts of interest. These are the doors to the Vanderbilt Medical ICU where I practice. And through these doors, and doors like them all over the world, pass patients whose lives literally hang in the balance. And we, as critical care doctors and nurses and pharmacists, our job is to save those lives whenever we can. And for many years, more patients died than survived. And so when a patient lived and came back out of those ICU doors to head to the ward or to head home, we considered those doors to be a finish line. And we're getting pretty good at acute critical care, as these data from the ANZIX group indicate, published by Maya Kokkonen and JAMA back in 2014. And what she did was look at over 1 million ICU hospitalizations in Australia and New Zealand from 2000 to 2012. And then she looked at the adjusted odds of mortality. And you can see that for both septic in the blue and septic in the red and non-septic in the blue, that for critical illness, that mortality has decreased dramatically during that time. In fact, in 2012, the odds of dying from critical illness were about half of what they were in 2000, which is great. That's our finish line for many years, right? We pat ourselves on the back and say, job well done. But there's another kind of hidden trend that's happening for our patients. Our patients are surviving, but they're not going home. They're not going back to the lives they had before. As we heard in this prior session, it's an uphill battle for them. And these were the gentlemen who are doing well after critical illness. Many patients today are discharged to rehabilitation centers or to nursing homes after their critical illness. This time we're looking at the adjusted odds of being discharged to a facility rather than home. And you can see that over time, those odds have actually tripled. And so what I want to posit to you today is that we should view these doors not as a finish line, but really as a starting line for our patients. Their lives are going to be forever changed by the time they spent in the ICU and by their critical illness. I want to talk about 3 topics today. The first is to talk about the disabilities and impairments that comprise what is known as the post-ICU syndrome. And then we'll talk about a hypothesis that comes from our colleagues in geriatrics called the vulnerability hypothesis. They've studied impairments and disabilities for a number of years, way ahead of where we are. But they have this hypothesis called the vulnerability hypothesis that can be particularly useful to us as we start to study why PICS may develop and how we can modify patients' chances of developing PICS. And finally, we're going to highlight some areas in need of future research to reduce that price for survival for our patients. So we know from a variety of cohort studies over the last decade and a half that 30 to 75% of patients will develop physical disabilities and physical impairments that range in severity from weakness and fatigue all the way up to complete dependence on other people for carrying out their basic activities of daily living. An equal proportion will suffer from cognitive impairment that ranges in severity from thinking and memory problems all the way up to severe Alzheimer's-like dementia. And finally, an equal proportion as well will suffer from mental health impairments in the form of anxiety, depression, and post-traumatic stress disorder. And in 2011, the Society of Critical Care Medicine convened a roundtable of stakeholders engaged in the care of patients after the ICU. And they coined the term post-intensive care syndrome. And post-intensive care syndrome is used to describe new or worsened physical impairments, cognitive impairments, and mental health impairments that frequently accompany survival from critical illness, again, in varying severities. Now, what I'm not going to talk about today is there's another component to the post-ICU syndrome, that which affects families. We got to recognize that husbands and wives and sons and daughters are also going through these survival issues. But we'll focus today on the physical, cognitive, and mental health impairments. And because this is a relatively new syndrome, having been described only about 5 years ago, we don't yet understand who's going to develop these problems and why. But our colleagues in geriatrics have been studying physical impairments, cognitive impairments, and mental health impairments in the context of aging for decades. And so now I'd like to introduce to you the vulnerability hypothesis to describe how PICs may develop, and then use that to discuss how we can modify patients' chances of developing PICs. So this is the vulnerability hypothesis of aging. This slide is borrowed from one of my mentors, Tom Gill, who studies disability and disabling processes in aging. And what the disability process looks at here is we have the acute stressor on the y-axis and vulnerability here on the x-axis. And disability develops as a function of these two things. So we'll look at this in the context of critical illness. So we have critical illness now on this axis and vulnerability here, patient vulnerability. And so if we have a patient who's relatively young, maybe a very, very healthy person, has pretty low vulnerability, and they develop a critical illness of moderate severity. Say they develop pneumonia with septic shock and come into the ICU. Because that patient has a low vulnerability, they're less likely to develop post-ICU syndrome. Now take that same patient and throw on a couple more organ failures. Now they're intubated with severe ARDS, they develop delirium, they're immobilized for a period of time. The severity of that critical illness all of a sudden goes very high, and it could be high enough to cross this line where that young, healthy patient with low vulnerability could go on to develop post-ICU syndrome. Now let's go back to our moderate severity of illness person or a moderate critical illness person, and let's this time alter the vulnerability here. As the patient's vulnerability changes, say now this is a person with multiple comorbidities, maybe they have a malignancy, what have you, their vulnerability to poor outcomes increases, and so it takes that same critical illness, that same severity of critical illness, and that patient will go on to develop post-ICU syndrome. So how do we measure this vulnerability clinically? Well, clinically, it's operationalized as the syndrome frailty. And frailty is a multi-dimensional syndrome that's characterized by the loss of physiologic reserve across multiple organ systems that reduces a patient's ability to maintain or to restore homeostasis in the setting of an acute stressor. Now that's a mouthful, so I'm going to walk you through on this slide conceptually what frailty is. So we have a patient's functional abilities over time. And we can think of patients that exist on this fitness to frailty spectrum. So if we take a patient who's very fit, say a young person, no comorbidities, and they develop pneumonia, they may suffer a little bit of a drop in their functional abilities, but they ultimately recover very quickly and back to their baseline. Let's contrast that with a patient with frailty here in the red. You see that they start out with more impaired function, and that pneumonia is a lot bigger deal. They suffer a more dramatic drop in their functional abilities. Moreover, recovery is a lot slower for these patients, and they may not ever recover back to their baseline. So we measured frailty in the context of critical illness in this paper that was just accepted to the Blue Journal. And to measure frailty, there's a variety of tools, but we use one called the Clinical Frailty Scale that assesses patients on a 7-point scale from fitness with a score of 1, very fit, these are the healthy, active people, to a score of 7, severely frail, these are the people with very severe disabilities in their activities of daily living, completely dependent on other people for lots of different things. And scores of 5, 6, and 7 indicate the presence of the syndrome, frailty. So we assessed this at ICU admission on a cohort of over 1,000 people. And the first thing that we found was that frailty is traditionally considered a syndrome of aging. So that would be this category here, these patients 65 years and older. And we found a range of scores. There were people who were very fit and older adults and people who were very frail and older adults. But when we looked at the younger patients, these patients in their 50s and 60s, and even in their 30s and 40s, we found a range of scores in patients that were admitted into this cohort study. And importantly, half of the patients in this study who had frailty, a score of 5 or more, were younger than the age of 65. So this suggests that there may be a little bit of a shift in terms of risk for patients developing critical illness who are frail, even if they're young. We then adjusted for a bunch of different potential confounders of the association. We looked at the association between frailty at ICU admission and long-term outcomes, looking at disability in instrumental activities of daily living here at 1 year. And after adjusting for baseline disability status and their activities of daily living, cognitive status, age, comorbid medical conditions, and so on, we found that as the clinical frailty score increased, so did the adjusted probability that patients would be disabled in instrumental activities of daily living at 1 year. So we can predict, essentially, before people get sick, what their outcomes may be after the ICU. Now, this vulnerability, once patients come to us in the ICU, isn't very modifiable. People show up in your, at least in my medical ICU, and no one plans to get septic. So we can't really, implement plans to adjust this vulnerability. But one thing we do to patients that can tip them over from no PICS to PICS is make their severity of illness or make their critical illness worse. And there's two syndromes that I'm going to address today that are very common. We heard it discussed a lot in the previous session, and those are delirium and immobility. And it may be the case that these two syndromes, in company with other things that happen in the ICU, can be enough to take a patient who wouldn't develop PICS for a given severity of illness and make their severity of illness worse such that they go on to develop post-ICU syndrome. And this could particularly be important for these highly vulnerable patients who come in with a low severity of illness. Those patients certainly have a lot less room to go to tip over into post-ICU syndrome. And so, how are delirium and immobility related to long-term outcomes? Long-term outcomes. Well, in the context of the brain ICU study that our group published in the New England Journal in 2013, we looked at the association between delirium and long-term cognitive impairment. We enrolled over 821 patients and followed them in the hospital and then assessed their neuropsychological status at 3 and again at 12 months. We used a test called the R-bands, which is a repeatable battery for the assessment of neuropsychological status. Think of it kind of like an IQ test, but it assesses a variety of cognitive domains. And lower scores indicate worse cognitive functioning. And you can see here that the longer patients had delirium, the worse they did on these scores. Such that if we compared patients who had 5 days of delirium, which was the 75th percentile for this cohort, to patients who had no delirium, there was about a 6-point change, which was almost a half standard deviation change in that test. So clinically significant worse cognitive impairment associated with delirium. The data for immobility and ICU-acquired weakness come from Dale Needham's ICAP study, published here by Eddie Fan in Critical Care back in 2014. And in this study, they enrolled over 200 patients with ARDS and assessed their physical functioning afterwards, at hospital discharge 3, 6, 12, and 24 months afterwards. And then they looked for a bunch of potential risk factors, such as age, comorbidities, whether patients received paralytics and steroids, the days they were delirious in the ICU, whether they received any physical therapy. And while age was the strongest predictor, so in other words, the older you are, the more likely you are to be weak at 2 years, that's not very modifiable. They also found that each day of bed rest, such that was a significant predictor at more than 3 of the 5 time points, which was their a priori definition of a significant risk factor. Such that each day of bed rest in the ICU was associated with 11% decrease in the muscle strength, the MRC score. So here we have our data to suggest that bed rest contributes to ICU-acquired weakness. Certainly not the only factor that does, but one of the modifiable ones. So if we hypothesize that delirium and immobility can make people have a higher severity of illness and develop post-ICU syndrome, is it possible that we can reduce delirium and reduce immobility and potentially reduce PICS? Well, we don't know. That study hasn't been done yet, but we certainly can reduce delirium and we can reduce mobility. And I'm going to go through a series of trials now that show us how we can do that. Perhaps the biggest trial to date that's looked at the effect of sedation on delirium comes from the SEDCOM trial published by Rich Reichert and Yahya Shahabi in JAMA back in 2009. And this was a RCT that compared midazolam to dexmedetomidine. And the primary outcome of this study was efficacy of level of sedation, and they were equal in that regard. But when they looked at delirium, they found something very interesting. Here we're looking at the proportion of patients who are delirious over time in this study. And the proportion of patients who received midazolam is in the red, dexmedetomidine in the blue. And you can see that at study enrollment, the groups are relatively equal. About 60% of the patients had delirium. And if we follow out the midazolam group, there's really no change across time. About 50 to 60% of those patients remain delirious during that first week of the study. But look at what happens in the dexmedetomidine group. There's a dramatic decrease in the proportion of patients who have delirium. So we don't know if this is an effect of dexmedetomidine itself. It certainly could be. Or is it an effect of getting rid of benzodiazepines, which are also associated with the development of delirium? So we need to look a little bit further into that. But simply by changing our sedation practices, we may be able to alter delirium. What about immobility? Early mobility has certainly been a hot topic in the United States, and looking at some of the poster session this morning, certainly a topic there. There's been 4 large randomized trials of early mobility that have been published, and 3 of them have come out in the last year, and so I'd like to discuss those. The landmark study was the Schweikert paper published in Lancet back in 2009, followed by the Moss study in the Blue Journal last year, Pete Morris's study in JAMA in 2016, and the Schaller paper that came out in Lancet late last year. So I'm going to present these sort of in a table format here, not go into the specifics of the trials too much, but there were differences in the type of intervention and in the intensity. None of the outcomes impacted actually muscle strength. Although we sort of deploy early mobility to preserve muscle strength and function, these trials have actually not shown that. What they have shown is less disability. So in the Schweikert paper, greater proportion of patients had preserved IADL and ADL and IADL function at hospital discharge. The Moss paper, there was absolutely no effect. The Morris paper looked at a mobility test at 2 months, and 2, 4, and 6 months, and there was positive findings in that, but it was very sort of late from the mobility intervention itself. And then the Schaller paper showed less disability in mobility and other ADL functions using the functional independence measure. So essentially, we have a positive trial, 2 negative trials, and another positive, so 2 and 2. So what might make the difference for why these trials are positive, aside from potentially the interventions themselves, although they weren't all that different between these 2 positive trials? Let's look at the sedation and the effect on delirium in these trials. In the Schweikert paper, early mobility was preceded by a daily spontaneous awakening trial where sedation was turned off. Patients were allowed to wake up, and then they could participate in mobility interventions. In the Moss paper, there was a sedation protocol, so they didn't turn the drugs off. They just tried to titrate a lighter level of sedation. But we know from other trials that this isn't always effective at reducing the overall level of sedation. The Morris study, there was actually no sedation protocol. So it's potential that patients stayed, even though they got intensive 3 times a day rehab, they were too sedated potentially early on to gain a benefit. And in this Schaller study, they had daily spontaneous awakening trials, again, reducing the sedation that patients received, and there was an overall effect on delirium. So certainly, this is sort of a hypothetical model, but we think these are probably all related. Delirium and certain types of sedation are associated with more delirium. Patients who are agitated, what our first response is typically to give them more sedation, to sedate them. So this is sort of a 2-way street here. We know that if people are over-sedated, they're not going to get mobilized. So depth of sedation is important. And a recent observational study from the ARDSNet in the United States looked at delirium's effect on mobility, and patients who were delirious were about 40% less likely to get mobilized in everyday clinical practice. And we saw the effect of mobility on delirium. Patients who got moved around potentially had less delirium. So these 3 are kind of interrelated here, and they may be, it's possible, although the studies need to be done still, that these 3 can affect a patient's odds of developing the post-ICU syndrome in the context of this vulnerability model. So now I'd like to highlight some areas that are in need of future research to reduce the price for survival. These data from Allison Turnbull at Hopkins show the overall number of studies and RCTs in critical care. And we can see that it really took off in the 90s, and now both all studies and critical care studies, and now there's nearly 1,000 RCTs in critical care every year. Let's contrast that with the studies on ICU survivors. So notice the scale difference, right? Here we're looking at 0 to 1,200. Here we're looking at 0 to 30. So even though the curves look similar, there's a huge magnitude difference between these. And so we've got lots of studies. These are mostly observational studies and such. And in fact, even on the best year, there's less than 10 RCTs. So we have a lot to learn about what ICU survivorship is and how to improve it. The second thing I'd like to highlight to you is post-ICU syndrome the right term for us to be using? It's certainly useful for raising awareness. We didn't talk about post-ICU syndrome 5 or 10 years ago, and now we do. These data are from our brain ICU cohort, and what we looked at here was the co-occurrence of symptoms of post-ICU syndrome. So cognitive impairment, physical impairment, and mental health impairment. And while it's sort of, we sort of think that patients have these overlapping symptoms, that all patients who come out of the ICU have cognitive, physical, and mental health impairments, in our study we only found 4% of people had symptoms in all three domains. And the other thing I think we do forget from time to time is that there's people who come out of the ICU and actually do okay. In this study we found 40% at 1 year were free of any problems. So we sort of forget that, and we don't understand who those people are and what they look like. So certainly, we got to study more about vulnerability during and after critical illness. And it might be the case that people exhibit different vulnerabilities. For example, you may have low vulnerability to mental health impairment afterwards, but higher vulnerability to developing cognitive impairment or physical problems. And critical illness, the severity of it, and other risk factors that happen during the ICU may also affect whether or not you develop physical problems, cognitive problems, and such. So we have to, I think there's more heterogeneity to the population, and we have to get smarter about what people are going to develop, what problems, so we can deploy effective interventions. The other thing is, very rarely do patients, in the observational trials, we try to get rid of a lot of this noise, right? We exclude people who have too many chronic problems or frailty, or in our brain ICU study, cognitive impairment. But that's not necessarily reality of how people come to us in the ICU. So there's sort of a pre-ICU syndrome. And in fact, there's emerging data that suggests that patients with cognitive impairment may be more likely to develop pneumonia and sepsis. And then it kind of gets in a cycle, right, of those patients then also develop worsening cognition. Similarly, with mental health problems, patients may be more likely to develop critical illness in that setting. So there's kind of some two-way streets and some interactions that we certainly need to tease out further. Then the second thing is, this all leads to patients' vulnerability to developing critical illness. And while the patients that I take care of in the medical ICU don't have planned ICU admissions, certainly patients that get admitted to surgical ICUs do. We know that patients going in for a big surgery may land in the ICU. Those people are predictable. And so is it possible to adjust the patient's vulnerability preoperatively? In other words, go through a prehabilitation program so that we can shift their risk. Maybe this person was highly vulnerable before and we know that they're going to become critically ill after their surgery. Can we, through physical rehabilitation or cognitive rehabilitation, shift them into an area like this where they still develop the critical illness? We can't do anything about that, but we've shifted their risk along the vulnerability spectrum. So we've talked about what the post-ICU syndrome is, and we've talked about the vulnerability hypothesis and how that affects patients' probabilities of developing post-ICU syndromes, and highlighted some needs for future research to further reduce that price of survival. Thank you very much, and I'm happy to take questions now.
My presentation is open for questions from the floor. Please.
Yeah, Ned, excellent presentation. Very interesting, of course. With regard to the term PICS we are using now a couple of years, I'm wondering, is that a good thing or is it a bad thing in the way that it's such a heterogeneous concept? And I'm wondering, whether the overlap between physical outcome and cognitive mental health outcomes is that good way to investigate patients.
Right.
In the way that cognitive and mental health outcomes are very much related, while physical outcomes may not necessarily be the case as you showed.
Right.
Could you comment on that?
So is PICS a good term to use? I think
Yes.
for the time being it still is, because we're still trying to raise awareness. We get lots of stories of patients whose primary care or general practitioners don't know anything about what they've just been through, how their families think they should be all better because now they're out of the ICU, and they're clearly not. So I think in terms of that, it's very useful. But I think there's more. We shouldn't just stop at, oh, they have PICS, because PICS isn't probably just one problem. It's, there could be up to 8 or 9 different problems there. And then in terms of the overlap between physical and cognitive, the brain-body connection is really interesting, right? There's pro-cognitive effects of exercise interventions and that sort of thing. So I think that's an area of further research. We need to understand how those interact in patients with critical illness. And there's certainly evidence suggestive of it already in those early mobility studies that also reduce delirium, and we don't understand why that is yet, but potentially moving around may help you clear your brain.
Nathan, having the information on the frailty index at the entrance in the unit, did you change your approach to the patient accordingly to the severity of frailty or not? Because you plot the 2 domains, frailty and the severity of a disease. And if the patient have low frailty, as the 2 patients we saw before in their experience presentation, probably the intervention will have will be easily obtain the outcome we want, avoiding the post-intensive care syndrome. But the patient with very high frailty, even if we make a lot of effort, probably we are not able to reduce the burden of the disease. So did you modulate your intervention according to the frailty index at the entrance of the unit?
Yeah, so our unit, we don't triage based on that. And so we actually don't end up having to triage many people. But I know where beds are restrictive, that can make a potential difference. I'd caution, we also show in that paper that frailty score is associated with mortality at 1 year. But I would caution, because we can't apply those data specifically to one patient and say, you know what, you're highly frail, even though I think we can look at patients and sort of understand who's probably going to do poorly. We sort of do that anyway, clinically in the intensive care unit, and sort of guide those patients towards, not aggressive therapies and that sort of thing, because we know the benefit on the back end is going to be pretty minimal. But I think that's an area that we need to look at further of the clinical applicability of these frailty scores and what they mean for individual patients.